Very good afternoon, Dr. Masaki. A very warm welcome from India. And it's great to see you after a few years.
Okay.
So, Dr. Masaki,
Thank you very much for your kind introduction. My name is Masaki Murakami. I'm from Shizuoka, Japan. I will talk about managing AV access beyond the first decade of dialysis. In Japan, the rate of kidney transplantation is very low. 97% of Japanese ESKD patients selected hemodialysis, while only 3% of ESKD patients selected peritoneal dialysis. According to Robinson, the mortality rate of dialysis patients in Japan is low compared with the United States and European countries. In another country, kidney transplantation and peritoneal dialysis are major KRT modalities. On the contrary, most Japanese ESKD patients selected hemodialysis. Furthermore, the mortality rate of Japanese ESKD patients is very low. Therefore, most Japanese ESKD patients have been undergoing HD for a long time, sometimes over 30 years. Managing vascular access beyond 3 decades of dialysis is necessary. This slide shows the choice of dialysis access in Japan. AVF is selected as the first option. AVG should be constructed as the second option. In general, central venous catheter is the third option. However, the patency of CVC is low. To continue hemodialysis treatment for a long time, another option is necessary in Japan. Brachial artery transposition is selected as a tertiary option in patients in whom a standard AV access cannot be created. The Japanese Society for Dialysis Therapy investigated the types of vascular access. 90% of HD patients have an AVF. 1.8% of hemodialysis patients undergo HD with brachial artery transposition. Therefore, more than 3,000 patients undergo dialysis with BAT. BAT is selected as a tertiary option in patients in whom a standard AV access cannot be created. The indication for BAT were as follows: an inadequate vessel for AV access creation, severe heart failure, hand ischemia, and central venous occlusion. I will give a case presentation with central venous occlusion. According to Kundu, treatment options for central venous disease include PTA, bare metal stent, and surgical bypass. Unfortunately, all the available treatment options have poor long-term patency requiring repeated interventions. In the ESBS guideline, the several surgical techniques using prosthetic graft for the patient with central venous occlusion are described as a tertiary vascular access. However, the risk of these surgeries were relatively high. According to this guideline, individuals should not undergo these surgeries without serious consideration. There is no ideal treatment for central venous occlusion. This patient was 70-year-old male. AV access location was left brachiocephalic AVF. Clinical abnormality was severe edema with chronic skin inflammation. He had been undergoing HD for 20 years. PTA is a primary option for central venous stenosis. PTA was performed for central venous stenosis in 2013. PTA was successful. However, the patency was relatively low. PTA had been performed in total 17 times to maintain central vein. Finally, central vein was occluded, PTA was failed. After that, ulcer because of venous hypertension developed. Therefore, additional procedure was needed. Before operation, we evaluated the vessel using ultrasound. The diameter of the brachial artery was more than 4 mm, which is adequate for cannulation. We can detect non-thrombosed vein. The diameter of non-thrombosed vein was more than 4 mm. The vein is available for returning route. Detection of the returning route is the key to successful VAT creation. Before brachial artery was transposed, AVF was ligated in November 2022. After 1 week, arm swelling and skin inflammation diminished. Then we created brachial artery transposition. The surgical technique is relatively simple. About 15 centimeter skin incision was made at the medial side of the brachial artery. A long incision and exposure were needed for repeated cannulation of the brachial artery. The brachial artery was exposed. Care was taken to avoid the damage to the median nerve, which lies near the brachial artery. Side branches of the brachial artery were ligated carefully using 407. The diameter of the brachial artery is more than 4 mm, which is adequate for cannulation. We created skin flap. The thickness of the skin flap is important. If the skin flap is too thick, cannulation of artery is difficult. If the skin flap is too thin, risk of skin necrosis is high. The subcutaneous tissue under the brachial artery was sutured. A skin flap was covered over the transposed brachial artery. Finally, we sutured skin. You can see transposed brachial artery here. After 3 weeks, transposed brachial artery could be cannulated. The patient was followed up after surgery every 6 months. VAT has been used without any intervention. Although brachial artery transposition has been used for several decades, there have been few studies. Therefore, we conducted a multi-center study to evaluate this technique. From January 2012 to December 2013, 5,000 vascular access-related surgeries were performed at 10 participating hospitals. During this period, 233 consecutive patients who underwent brachial artery transposition were included in this multi-center retrospective study. The indication for brachial artery were as follows: an inadequate vessel for AV access creation, severe heart failure, hand ischemia, and central venous occlusion. Here the result. Successful rate was 98%. Because the surgical technique is simple, the first successful cannulation was achieved at a median of 18 days. The primary patency of the transposed brachial artery was 93% and 88% at 1 and 3 years, respectively. The primary patency of the transposed brachial artery itself was high. The primary patency of access circuit was 64%, and the secondary patency of access circuit was 74% at 1 year. The patency of access circuit was not so high. The main reason for the failure of access circuit was dysfunction of a return route. During the follow-up period, 13 impaired wound feeding, 6 large aneurysms, 5 plaque artery thrombosis developed. Complication rate of BAT was relatively low. BAT differs from normal AV access in several aspects. One of the advantages of BAT is no maturation time. The diameter of the plaque artery is generally adequate for cannulation. Another advantage of BAT is favorable patency. BAT can be created without any artificial material. The patency is high without intervention. Therefore, BAT is an economical technique. When we create AV access, shear stress may lead to stenosis. In contrast, the plaque artery is simply transposed in this operation. Therefore, arterial blood flow is almost physiological except during the hemodialysis session. Such hemodynamically normal flow should provide better patency for this method. However, BAT has a critical disadvantage. Adequate normal vein are necessary as a returning route. Plaque artery transposition is insufficient for vascular access by itself. Therefore, if the vein used for the return route have been wasted, the transposed artery becomes difficult to use. Arterial cannulation is not common for foreign doctors. Firstly, a normal superficial vein was cannulated using tourniquet. Then the transposed artery was cannulated without using tourniquet. She is not a doctor. Medical staff perform cannulation of transposed brachial artery. The cannulation method for BAT was basically the same as the AV fissure. Cannulation of the artery is comparatively easy. The diameter of the brachial artery is more than 4 mm. In fact, cannulation of the normal vein using 17-gauge needles is sometimes difficult. After removal of the cannula, adequate pressure to the brachial artery was applied to prevent bleeding. The normal vein was compressed for 5 minutes. The brachial artery was compressed tightly for 5 minutes, followed by another press for 10 minutes with moderate pressure. The risk for bleeding is relatively low because a brachial artery was superficialized and easily to be compressed. Furthermore, repeated cannulation and hemostasis make the arterial wall thick and stabilized. According to a national survey, the KTV was similar in 3 groups. Patients with a temporary CVC show the lowest dialysis adequacy. In patients with BAT, the risk of recirculation was low because a different route was used for blood return. The dialysis adequacy in BAT cases is similar to AV access cases. KDOQI guideline suggests central venous occlusion is one of the major problems and represents the Achilles heel of vascular access. There is no ideal treatment for central venous occlusion. Generally, angioplasty is the primary option. If a return route cannot be detected, graft bypass or catheter at the opposite site is an alternative option. Although it seemed difficult to perform a new procedure in your country, central venous occlusion can be treated by economical surgical procedure using brachial artery transposition. Thank you for your attention.
Thank you, Dr. Masaki. One question. Can you shed some more light about the returning vein? How do you select it? And which all veins, and how do you make sure, because these veins don't have higher blood flow in normal scenarios, how you keep patency about? And do you use even
Yes,
STP for that? Yeah.
actually, detection with the return route is the key to successful BAT creation. So, if we cannot detect the returning route, we cannot perform brachial artery transposition. And for example, in the central venous occlusion case, we can detect many collateral veins. So if we ligated the main AVF, we can detect many collateral veins which can be cannulated. Then we will use these collateral large veins.
So if I get it right, these are patients who have central venous obstruction with a swollen arm, and anyways, these veins have a good dilated peripheral veins. So once you do ligate the fistula, and
Yes.
you wait for almost a week, once the arm swelling is down, then that same patent vein, you use it as a returning vein, right?
Yes, that's all. That's all.
Yeah, I mean, it's wonderful, and also sometimes solutions can be so simple, because I didn't see any metal, any wire, and and any drug-eluting balloon, which, as you rightly said, that sometimes there is no ideal treatment for central vein occlusion, and it's a dead end, because, as you mentioned, one patient 17 times PTA. We ourselves have patients who have got keep on just getting one, and then so many times you're putting foreign bodies and the lines and wires inside. You are exposing them for more and more of infection. Any question from the audience? Any comment? Dr. Neelam?
So wonderful talk. I have a question. One of the indications that you said of this brachial artery transposition is hand ischemia. So in such cases, how do you deal if an ischemic complication then occurs following the procedure?
After the brachial artery transposition, the risk of hand ischemia is very low. So when we created AVF, hand ischemia sometimes occurs. On the contrary, when we created brachial artery transposition, the risk of hand ischemia is very low, because artificial blood flow is almost physiological, except during the hemodialysis session.
So I noticed one thing. You use plastic needles for the cannulation in the video.
Yes.
So is it only for the BAT procedure, or across you use plastic needle for the cannulation? For
Actually, for the AVF or AVG, in Japan, a plastic needle is used for AVF or AVG. So the needle is the same as for AVF or AVG. Actually, in Taiwan, in another country, they performed BAT. In Taiwan, metallic needle is used for BAT. So, in my opinion, metallic needle is available for brachial artery transposition.
Well, Yeah.
Just one question. Arteries are known to undergo spasm. So, do you encounter anything like that when you are, needling it for dialysis on a
Can you
regular
focus the
basis?
camera?
The brachial artery. Any spasm that comes in the way of dialysis?
Actually, the risk of the spasm is very low when we candidate the BQT.
Any contraindication to any artery? Which artery you cannot, apart from size, as which you have already mentioned?
If the diameter of the brachial artery is more than 4 millimeter, is a good indication for BAT. And the diameter is more than 3.5 millimeter is adequate indication.
Heavy calcification, calcified arteries, because sometimes they may be difficult to, I don't know, lift. Calcification in the artery, does it matter?
Actually, we sometimes used calcified brachial artery for this operation. So, in my opinion, calcified brachial artery is not a problem for brachial artery transposition. But if in your country, if you perform brachial artery in the first case, you can select non-calcified brachial artery. Because we gave a case presentation in this patient, but you can see the calcified brachial artery using ultrasound in these cases.
Well, thank you, Dr. Masaki. If there's no question, I would like to thank you for giving this wonderful talk. We hope that we do learn few things from their talk, and most importantly, looking from the different angle that central venous can be actually treated by not even treating that itself. So thanks a lot, and it was wonderful having you.
Thank you very much.
So now I'd like chairpersons to continue with the session, please.